Hi, everybody. Thank you very much for joining me. Today, we'll discuss the role of PET-CT scans in prostate cancer imaging. I'm Vital Savir-Baruch from Loyola University Medical Center. Those are my disclosures. And today in this educational lecture, we'll cover the limitation of conventional images in the localization of prostate cancer. We will speak about the application of fluciclovine and PSMA, and we will really briefly cover the concept of ablation therapy. So let me start with a case. This is a patient that presented with low-risk prostate adenocarcinoma back in the years. He did present with biochemical recurrence in 2016. The assumption was that he has local recurrence despite negative CT and bone scans, but fluciclovine images actually showed different findings, including retroperitoneal lymph node and bone lesion. So he was not a candidate for salvage radiation therapy anymore, and he started hormonal therapy. And we'll come back to this case later on. So prostate cancer is the second most common cause of cancer. It is important to understand that 50% of the patients that will be treated for prostate cancer will present with biochemical recurrence. The localization of disease is very important for management, but conventional images in a setting of low PSA level will be usually negative. So let me show you an example. This is one of the early cases. You can clearly see that the CT images showing benign lymph node, yet the uptake on fluciclovine is very suspicious. And this is one of the early evidence that metastatic disease from prostate cancer can be in small subcentimeter benign appearing lymph nodes on conventional images. So let's go over the concept of functional images. We do know that we have the mostly commonly used in oncology images, F18 FDG. It's a sugar base. It goes through the cell via GLUT transporters, and it will mimic metabolism, but it will not be metabolized. It will also be trapped within the cell once it goes in. Now, when it comes to prostate cancer, we don't commonly use it because the upregulation of GLUT transporters in prostate cancer is variant between different histology, from differentiated to poorly differentiated. C11 choline, you guys are familiar with that agent. It is selectively used in a certain place, and it is mimicking cell proliferation. We do have C11 acetate. It is not FDA approved and been used under investigation into certain hospitals. The C11 acetate will incorporate into amino acid and fatty acids pathway, and therefore will trace energy, metabolism, cell proliferation, and synthesis of proteins. F18 fluciclovine will go into the cell through amino acid transporters. It will trace metabolism, cell proliferation. It will not be metabolized, but compared to FDG, it will not be trapped within the cell. Prostate-specific membrane antigen, it is the older method, was processing to designed to attach the intracellular binding, and it's not widely used because it is very long and hard process for the molecule to go into the cell to do that. The newer method will be to target extracellular binding site on the PSMA protein, and we'll discuss that today. So briefly on the fluciclovine, which is an amino acid-based tracer, it is synthetic. It will go to the cell through the amino acid transporters, but will not be metabolized. It is indicated for biochemical recurrent disease, not for initial disease, based on the elevation of PSA. The normal distribution is increased uptake. You'll see increased uptake within the liver and the pancreas. Pancreas will be the organ that will receive the majority of the radiation. You can see how there is more uptake in the skeletal muscles in the upper body, and that's because we start imaging within the pelvis and we go up to the chest, and the uptake is increasing within the muscle with time. It is much different than fluciclovine, than FDG, and you do want to be familiar with the distribution of those tracers because that can come across your boards. Sensitivity of fluciclovine is very high for prostate local recurrence, but not very specific. As you can see, high rate of false positives. For extraprostatic disease, specificity is very high. Sensitivity is 57%. It is very high compared to conventional images, because when you go here, you can see that if you use size criteria, sensitivity is 11% compared to 46% with fluciclovine based on uptake. So it's not easy to read. You can see here that there is a suspicious lymph node. Let me make that a little bit bigger. So now you can see the lymph node I'm talking about. Now you really need to get used to reading it because you want to look at those lymph nodes in different projections, such as this one. And you can see that the uptake is in fact equal to marrow, and it is by visualization, not based on numbers, by the way. If you look at the numbers, it's not. But if you look at the uptake, it is equal to marrow. It is significantly above that of the aorta, and therefore considered to be suspicious for malignancy. The problem with it is the same patient, just a little bit below, and you can see there is a cluster of lymph nodes. So with sub-centimeter lymph nodes, we do give ourselves the option to understand that if there is cluster of lymph node with mild uptake, even though it's not approaching the marrow, it's not significantly above aorta, and essentially should not be called positive, it is still suspicious because it's a cluster of lymph nodes. And here it's probably suspicious just because we know there is another lymph node that was biopsy positive, but you probably don't want to call all of those lymph nodes that you see, because then you decrease in specificity significantly. So jumping into the reading criteria that you want to be familiar with, we are dividing into likely benign, equivocal, and likely malignant. The equivocal meaning that the uptake is not meeting the threshold of malignancy. You want to ask yourself three questions. Is there uptake? Is the lesion above 1 centimeter? Is the uptake visually equal or above the marrow? So when patient had prostatectomy, you can see here in green, if there is no uptake, it's likely benign. If the uptake between blood pool and bone marrow, you should follow up on it. It's equivocal. And then if it's equal or higher than bone marrow, it's likely malignant. Those are the example of intense uptake within the anastomotic site. This is likely malignant. This should be likely benign. And again, likely malignant with focal uptake. For patients that had prior radiation therapy, no prostatectomy, the same concept, but now you can see that we're looking at diffuse focal or multifocal uptake that is equal or greater marrow. This is where you're going to call it malignant. So this is an example on the left side. Focal uptake was truly biopsy, and then cryo showed resolution, and this is an example of benign. And again, focal uptake in a little bit more, in a larger area in the prostate, likely malignant, and then homogeneous mild uptake, not much significantly above the blood pool, and therefore this is likely benign. So for lymph nodes, when the lymph node is equal to 1 centimeter or above, and that's based on size due to physics, we keep the same recommendations as I showed you before. We do decrease the threshold a little bit when the lesion is less than 1 centimeter, and that's just because the SUV max may be underestimated due to partial volume artifact. So right now, malignant will consider significantly higher than blood pool, but almost approaching the bone marrow uptake. This is where it becomes malignant. So those are examples of normal appearing lymph nodes on CT images, but with highly suspicious uptake that is very specific on fluciclovine, and another example right here. Now, it's not always the case, because sometimes you're going to see some inguinal lymph nodes that's going to be likely benign. And if it's an isolated findings without any uptake in the pelvis, you start thinking of benign etiologies. And the concept of inside out is very important, and I'll show it to you in the next slide. So typical locations are prostate bed within the anastomosis. You can see this example. Can even be next to the seminal vesicles bed. You can see abnormal uptake next to a clip. And then for a patient that had no prostatectomy, this is one of the examples that I showed before. Concept of lymph nodes, very important to know that for the exam. You want to look for inside-out pattern. The most typical uptake will be within the pelvis, goes up into the abdomen, and then outside into the external pelvis, meaning into the inguinal area or into the chest. So atypical presentation will be isolated findings in inguinal, hilar, or axillary lymph nodes. And you can see this is an atypical presentation of lymph node, but probably prostate cancer because it does follow the rules of inside out. You see uptake along the pelvic lymph nodes going up into the area of the abdomen and then travels up to the chest. On the contrary, we do have a patient with right axillary lymphadenopathy, small right breast lesion, and internal and intramammary lymph node, as well as bone lesions you can see on the right side on the MEEP. So clearly this is atypical presentation. It's likely breast cancer, and it was true biopsy to be breast cancer in men. So what about bones? We do know that intense uptake will be associated with lytic lesions. Moderate to intense uptake can be associated with mixed sclerotic and lytic lesions. Sometimes we'll have false negatives on dense sclerotic lesions, and this is where you're going to need to do some MRI or bone scans. In order to increase the specificity, we do recommend to look for those lesions on the MEEP images, such as in this example. So for fluciclovine and also for PSMA, some false positives are being shown, such as this example. The MRI was negative on the left side. We do see those presentations on iliac crest, in the iliac crest and the acetabulum. We do see that also on PSMA images in the ribs. So it's very important to understand the complete clinical picture before you call lesions within the bones. So we do know that the positivity rate is linearly proportional to the PSA level. We also know that the higher the Gleason score, the more likely that the patient will present with positive findings within the extraprostatic locations. We also learned that patients that are on hormonal therapy and experiencing biochemical recurrence have the same positivity rate as the population that does not take hormonal therapy, meaning that you can still use it while patient is on hormonal therapy. This is an example of patient that presented with abnormal uptake along the lower lumbar spine, and you can see that despite having hormonal therapy, he had failure of his PSA, and a patient at that time was diagnosed with hormone refractory prostate cancer. We know that fluciclovine can help change management in 60% of this population on the LOCATE trial. Fluciclovine change management with 78% major changes that one regimen was changed to another. Going into the future tracers, we do know now that gallium-68 PSMA 11 was recently approved for selective use in California. And we do have other tracers that are F18 labels and are under investigation, and I'm not going to cover that in my lecture today. So again, going back into the mechanism of action, now we are targeting an extracellular binding compared to intracellular. And this is the whole body distribution. So you can see there is uptake in the lacrimal glands, salivary glands, liver, spleen, kidneys, bowel, and excretion through the bladder. Compared to fluciclovine, the indication of gallium-68 PSMA 11 is on both prostate cancer primary, initial staging, and biochemical recurrence. What about the diagnostic performance? For initial detection, we have a lot of data, and we do see that the sensitivity on all studies is very high. Specificity is variant. Now, when we look at recurrent disease, we have less available data with histological proof, but for among those that are available, we do see that the sensitivity is likely higher than fluciclovine with somewhat similar specificities. So going into the main studies that had head-to-head comparison done, one in Europe and one in the United States. This is a subpopulation of patients from Europe that had PSA above 2. And you can see when you do subpopulation of it, there is no statistical significance between any of the detection rate of different location, even though there is slight benefit for fluciclovine for local detection rate and slightly better for PSMA for extra pelvic lymph nodes, and bone lesions. You do see that it's not probably significant. Now, when you look at the PSA less than 2 at this point, it is a subpopulation that included the entire cohort of the American study compared to the European study. And you can see that in this subpopulation, fluciclovine outperforming the detection rate for local disease compared to extraprostatic disease, that PSMA was outperforming fluciclovine. So this is how it looks. You can see here that both of them are positive, fluciclovine and PSMA, but the uptake is significantly higher here. It's easier to read probably. You can see that for fluciclovine, we do need to follow reading criteria, where PSMA, most of it is just above background. We do have some pitfalls with PSMA, and I'm not going to cover them right now, but some uptake may be slightly mild. And then you can see that for fluciclovine uptake for local recurrence, you see that there is uptake here in the prostate, where here it's masked by significant bladder secretion. So is this even clinically applicable? It is important to understand the effect of outcome, the effect on outcome, and in this study, which was just recently published as preliminary result, you can see that in a randomized prospective study where fluciclovine was used to guide radiation therapy compared to a group that only conventional images were used to guide radiation therapy, you can see that the failure-free survival was much better for the fluciclovine group at 3 years and 4 years. So this is one of examples from our own institution. It's the same patient I spoke about that fluciclovine actually changes management from radiation therapy to hormonal therapy, which is the best one to start with at that point. And you can see that at 2 years and 3 years, he had, despite hormonal therapy, at the 3-year time, he had progression of disease. And then at 4 years, they decided to do to give him Xofigo treatment. I treated him, and the post-Xofigo bone scan is shown on the right side, and you can actually see that his disease site significantly decreased. So 2016, it was presented to us, and now we are 2020, and is still very functional and doing very good in terms of quality of life. So let me introduce really briefly the concept of oligometastatic disease. We do know that by definition, it's between 1 to 5 lesions. We also know that for certain cancers, if you treat those lesions, you may have better outcome. We're starting to understand that concept for prostate cancer. We're not yet there, but you do want to remember that if you have a case, if you have a single small appearing lymph node that has uptake, this is probably prostate cancer, and you don't want to think this is not, as long as it's followed the rules that I told you before from the inside out. So fluciclovine, for among the patients in our institution, you can see here in the curve that in the graph that 80% of them had 5 or less lesions. And in fact, the majority of them had 1 or 2 lesions. And you can see on the right side that the distribution was predominantly within the pelvic lymph node. So again, it's the same rule of what I showed you. So going into the PSMA and outcome, you can see for progression, for biochemical progression, free survival, and other aspects of the outcomes, you can clearly see in the blue line that when you use functional images, and in this case, PSMA, to guide radiation treatment, the outcome is much better compared to just observation. So if before we started giving hormonal therapy to everybody that presented with positive lymph node based on size, now we are starting to understand, and maybe we want to be more selective. So we have the option of selective lymph node resection, like for diagnostic purposes, for treatment resections. We can radiate, if before we radiate the entire pelvis, now we can do selective radiation. We can actually combine the two. There are some European studies looking at those concepts and showing that the outcome may be much better when you actually resect lymph nodes based on functional images, but we're still working through getting official recommendations. Some disadvantage of gallium PSMA is including the availability of it. As you all remember, gallium-68, it is produced by a generator. It have a limited supply. We will solve that problem with either different way of production or the F18 PSMA ligands, whatever will come first. We also know that patients that receiving a blockage of their androgen receptors may affect the PSMA expression and may actually result in overexpression of them. And we do know preliminary that that a long term of ADT usage may affect the sensitivity of gallium PSMA performance. So it is important to understand, number one, with fluciclovine, we can use that maybe for ADT. This is just a preliminary data, but it is important to understand that those two tracers may work together. It is apples and oranges. One is via amino acid, and it's important because that can come across in your boards as well. That is amino acid based on upregulation of those transporters. And on the other hand, we have a receptor base, which is structure dependent. So this is an example of a patient that had initial presentation with Gleason 9 of prostate cancer. You can see on the left side there are pelvic lymph nodes, abnormal bone lesion, and retroperitoneal lymphadenopathy. Patient started hormonal therapy. His PSA went down to 0.26, yet continued to raise while on ADT. So he presented for fluciclovine, and on the scan day, his PSA was 0.34. And you can see that the retroperitoneal lymph nodes were completely melted and had no uptake, and that's likely due to ADT response. However, he probably also has ADT-resistant cell line, because you can clearly see that there is intense uptake within the pelvic lymph node and the pubic bone. So let me jump into the significant benefit of PSMA family, because compared to fluciclovine, which we cannot offer Theranostic, we can offer that with the PSMA family. So what is the concept? You use nanoscience to actually diagnose a cell, and with the same linker, you can actually treat the same cell and kill it. So the concept is, when you have a cancer cell, you have then a target within the cell. You have a targeting agent that you synthesize, then you use a nanoscience linkage, then you put a radioactive agent. When it comes to prostate cancer cell, you see this is the PSMA, extramembrane binding. You synthesize the binding motif, you use a linker, and then for diagnostic purposes, you put either gallium-68 or F18, those are PET tracers. And then for therapeutic radiotracers, you're putting some ablation emitter. It can be alpha, it can be beta, and in this example, it's lutetium and Y90. So this is where the word theranostic or theragnostic is came from. So the concept is very simple. You use the diagnostic agent, as I showed before, in this case is gallium PSMA 11, to detect whether or not there is uptake. And clearly here you can see that there is a lot of uptake. And then you basically ablate with ablative agent, and then you use the diagnostic agent for surveillance, as you can see here, and you can also see how nicely that helped this patient. So in summary, what I would suggest you is to recognize the normal distribution of PET radiotracer. I only included here the prostate cancer, but there are other PET agents that, for example, the dotatate that was recently approved, so you want to be familiar with. For gallium-68 PSMA, again, lacrimal glands, salivary glands, liver, spleen, kidneys, bowel, bladder, fluciclovine, liver and pancreas, a little bit of muscles here, no brain, and then you're all familiar with FDG. So understand the normal distribution of prostate cancer disease, the concept of inside out. You want to have disease within the pelvis going out, unless the question clearly doesn't give you any other option to choose something else other than prostate cancer. Remember that both fluciclovine and PSMA tracer are very specific, and high uptake in normal size lymph node is likely cancer if it fits the pattern of disease, such as in this example. And also remember the prostate cancer recurrence most likely to appear as a oligometastatic disease. This is not uncommon. And the use of fluciclovine or gallium PSMA PET-CT scans shows better free failure rate survival compared to conventional images. So this is my email if you want to send me any questions, and thank you very much for joining me for this lecture.